Welcome back, everybody. This is Mike. We continue our discussion on management of diabetes in pregnancy, a clinical update. Today's topic is long-term consequence of GDM to the mother. The consequences of gestational diabetes. The importance of aiming to understand and effectively treat or prevent GDM is illustrated by the wide-ranging consequences of GDM for both the mother and the fetus. Now, what are the consequences of GDM to the mother? GDM increases the risk of a number of short-term and long-term maternal health issues. In addition to the stress of normal pregnancy, GDM is associated with antenatal depression. There is also an increased risk of additional pregnancy complications, including preterm birth and preeclampsia, and in many cases, surgical delivery of the baby is required. Approximately 60% of women with a past history of GDM develop type 2 diabetes mellitus later in life. Each additional pregnancy also confers a threefold increase in the risk of type 2 diabetes mellitus in women with a history of GDM. Further, women with a previous case of GDM have a yearly risk of conversion to type 2 diabetes mellitus of approximately 2 to 3%. Emerging evidence also suggests that the vasculature of women with a prior case of GDM is permanently altered, predisposing them to cardiovascular disease. A recent study reported a 63% increased risk of cardiovascular disease amongst women with a history of GDM, which may partly, but not fully, explain by body mass index. This is of major concern as cardiovascular disease is the number one cause of death in the world. Now, what about the long-term health of the mother? Women who are diagnosed with GDM are at high risk of developing diabetes mellitus later in life. An estimated 10% of women with GDM have diabetes mellitus soon after delivery. The rest appear to develop diabetes mellitus at rates of 20 to 60% within 5 to 10 years after the index pregnancy in the absence of specific interventions to reduce the risk of diabetes mellitus. Limited long-term data from O'Sullivan suggests that not all women with GDM will get diabetes mellitus, but certainly the majority will. Thus, as is true for perinatal complications, GDM is a risk factor for diabetes mellitus after pregnancy. However, the risk of diabetes mellitus in the mother after GDM is much higher than the risk of perinatal complications associated with GDM. Thus, GDM can be reasonably considered to be a form of prediabetes similar to impaired glucose tolerance in non-pregnant individuals. Diabetes mellitus after GDM can take several forms, but the majority of patients fit the phenotype of pre-type 2 diabetes mellitus. Longitudinal studies of glucose regulation after GDM reveals failing beta cell compensation for chronic insulin resistance that may also worsen over time. Risk factors for relatively early development of diabetes mellitus after pregnancy include markers of relatively severe decompensation, which include high glucose levels, marked insulin resistance, and poor beta cell function. Women with these characteristics do not have to deteriorate much to cross the line to glucose levels that define diabetes mellitus. Risk factors for relatively high rates of the deterioration in beta cell function that causes diabetes mellitus include weight gain, insulin resistance, rising levels of C-reactive protein, and falling levels of adiponectin. These findings suggest that metabolic effects of obesity are important determinants of the beta cell deterioration that leads to diabetes mellitus. Indeed, as discussed below, amelioration of adverse metabolic effects of obesity through weight loss or the use of medications that improve adipose tissue biology provide the strongest protection against development of type 2 diabetes mellitus following GDM. The background upon which type 2 diabetes mellitus develops is one of obesity and related conditions. that are often referred to as the metabolic syndrome. As might be expected, women who have had GDM manifest components of the metabolic syndrome more often than do women without GDM. The history of GDM is also associated with an increased frequency of cardiovascular risk factors and cardiovascular events. Now let's discuss how to protect long-term maternal health in GDM. A reasonably robust and growing body of clinical trial evidence exists concerning reducing the risk of diabetes mellitus in high-risk individuals. For individuals at high risk of developing type 1 diabetes mellitus, the evidence is that we do not have any interventions that work well in humans. For individuals at high risk of developing type 2 diabetes mellitus, the story is very different. Lifestyle interventions, metformin, acarbose, and thiazolidinediones have been used to reduce the risk of type 2 diabetes mellitus by 25 to 72% in adults with impaired glucose levels. The best evidence for risk reduction and disease mitigation comes from approaches that either change body adipose tissue content, like lifestyle changes which can produce about 58% risk reduction, or adipose tissue biology, using thiazolidinediones which can produce a 55 to 70% risk reduction. Evidence is less strong for approaches that primarily reduce rates of glucose appearance in the circulation, like acarbose and metformin, which can produce from 25 to 31% risk reduction. Two trials provide information for the specific case of women with a high risk of type 2 diabetes mellitus on the basis of a history of GDM. The droglitazone in the Prevention of Diabetes or TRIPOD study was conducted solely in Hispanic women with prior GDM. The study demonstrated a 55% reduction in the incidence of type 2 diabetes mellitus over a 30-month period. Protection from type 2 diabetes mellitus was associated with reduced secretory demands on beta cells and a significant slowing of loss of beta cell function. Preservation of beta cell function persisted when patients were switched to pioglitazone after droglitazone was withdrawn from clinical use. The U.S. Diabetes Prevention Program included women with a history of GDM as one risk factor for diabetes mellitus. A post-hoc analysis of the impact of lifestyle or metformin compared with placebo in women with self-reported history of GDM revealed a 50% reduction in the risk of diabetes mellitus with either intervention. Lifestyle was equally effective in reducing the risk of diabetes mellitus in women with and without a history of GDM, 50% versus 49% risk reduction, respectively. By contrast, metformin was more effective in women with and without a history of GDM, 50% versus 14%, respectively. Thus, metformin may be particularly effective in reducing the risk of diabetes mellitus in women with a history of GDM for reasons that are not clear at present. The limited available evidence suggests that assessment and reduction of cardiovascular risk should be an additional component of care for women with prior GDM. This ends our discussion on long-term consequence of GDM to the mother. See you next time when we discuss the long-term consequence of GDM to the child.